So this evening, we're going to be discussing what bariatric surgery is, who can benefit from it, and the different procedures available to help you lose weight and improve your overall health. I'd like to start by introducing tonight's speaker, Dr. Catriona Swift, a bariatric surgeon who is part of the Ascension St. Agnes bariatric surgery team, along with Dr. Andrew Auerbach and Dr. Isam Hamdallah. Dr. Swift developed a passion to pursue a career in bariatric surgery due to the many positive impacts weight loss surgery has on the lives of her patients, including reversing chronic diseases and improving their quality of life and overall well-being. Dr. Swift is trained in laparoscopic, robotic, and endoscopic techniques and offers the duodenal switch, gastric bypass, sleeve gastrectomy, revisional bariatric surgery, and endoscopic weight loss procedures, as well as surgical treatments for GERD and hiatal hernias. With that, I'd like to welcome Dr. Swift to tonight's presentation. Thank you so much for joining us.
Thank you very much, Kelly, and thank you to everybody who's tuning in. All right, so let's get started. We'll start off covering the fact that obesity is a disease, but this was not really established until 2017 in Europe. Sorry, I can't see my slides. There we go. 2017 in Europe by the Obesity Society. And in that, they finally came to the conclusion that obesity is a complex condition with lots of contributing factors, most of which are beyond people's control, that obesity causes a substantial amount of suffering, that it contributes to ill health, reduced quality of life, and other serious diseases, that successful treatment is difficult but produces many benefits, and that obese persons are subject to an enormous amount of stigma and discrimination, and frankly, they deserve better. As of 2018, 73% of Americans were overweight, 42% of Americans were obese, and of that subset, 9.2% are severely obese. However, even given those large numbers, obesity is not very well defined. Depending on which organization you look at, it'll say that obesity is an abnormal or excessive fat accumulation that presents a risk to health, or too much body fat, which is thoroughly subjective, or a BMI of greater than 30, which is really the only measure that is putting a number that we can use to determine who has this condition. Then that's further broken down into severe obesity, also known as morbid obesity, which is a serious health condition that results from that abnormally high fat percentage. This is defined by a BMI of greater than 40, or a BMI of greater than 35 with at least one serious obesity-related condition, or being more than 100 pounds over your ideal body weight. There are many different things that can cause obesity. Now, we hear a lot about genetics and hormonal imbalances, but these each make up less than 10% of the causes of obesity. Beyond that, there are a lot more social factors, such as larger portion sizes, the processed foods that are more accessible, quicker, and most of the time much less expensive, lack of access to fresh foods, physical inactivity. We have a much more sedentary lifestyle than we did even a few decades ago. Advertising, using food as a coping mechanism or a reward. And then there are psychological factors like underdiagnosed or undertreated psychiatric disorders, or the addictive nature of food. There are also a lot of new research going on with the gut microbiome. You probably heard about probiotics and things like that. So those are the bacteria that live inside of your gut, and they're finding that use of antibiotics and other things that can alter the balance of your gut microbiome can actually cause weight gain or weight loss. So why is this a big deal? Each 5-point increase in BMI over 30 or over 25, so 30, 35, then 40, is associated with a 30% increase in mortality. We see that even with 10% body weight loss, there are improvements in that higher mortality rate. Also, there are 86 known conditions that are caused or worsened by obesity and helped by weight loss, particularly with bariatric surgery. So one of the most notorious of these conditions is diabetes. There are lots of different complications with diabetes. This affects almost every body system. It includes nerve damage, blindness, damage to your kidneys, skin infections, wounds, heart attacks and strokes, gastroparesis, which means that your guts move a lot slower. We see substantial risk of infertility, sexual dysfunction, and even needing your limbs removed. So diabetes is a really big deal. And after 3 years of really intense medical therapy, including monitoring diet, and giving these medications, we see about a 5% remission rate in diabetes, which means that in 5% of patients, the diabetes goes away. However, with the duodenal switch, which is one of the procedures we'll talk about later, we see a 70% remission rate at 10 years. Immediately after surgery, that is about 92%. And of all patients who have diabetes and undergo the duodenal switch, 97% do see an improvement in their hemoglobin A1C. With the gastric bypass, we see a 50% remission rate at 5 years, which means that immediately after surgery, the diabetes goes away, and 5 years later, in half of patients, it's still gone. Both surgeries have also been found to improve hemoglobin A1Cs in type 1 diabetics, and this is the only treatment we've found that improves A1Cs in type 1 diabetics. So the cardiac, or the heart, and the blood vessel system. Obesity causes issues with high blood pressure, high triglycerides, high cholesterol. It increases your risk of heart attack, stroke, and congestive heart failure. After bariatric surgery, we see a risk of cardiac death drop by over 50%. The risk of a first-time heart attack or stroke is reduced by 15% over a 24-year period. Hypertension goes away at rates of over 90% initially and remains high at 63% at 5 years, and high cholesterol resolution at 65% at 5 years. And then we also see an improvement in the dysfunction that happens with congestive heart failure, even at 5 years. In the respiratory system, obesity affects or causes obstructive sleep apnea. It worsens asthma. It causes obesity hypoventilation syndrome, which means that the weight of your chest overpowers your lungs, which makes it difficult to catch your breath or oxygenate properly. It worsens COPD, and it worsens COVID-19. It doesn't necessarily make it so that you are more likely to contract COVID-19, but the complications and the severity of the disease is much worse. So we do see that sleep apnea resolves in 79% of patients with a bypass, 85% of patients with a sleeve, and 99% with the duodenal switch. We also see that because we have less issues with inflammation in the body tissues after surgery, there are fewer asthma and COPD exacerbation hospitalizations. So your asthma and your COPD both would improve. And then there's a substantially reduced risk of ICU admission, need for extra oxygen, and a decreased risk of death after COVID infection. For your muscles and bones and nerves, we see issues with osteoarthritis, rheumatoid arthritis, fibromyalgia, neuropathy, and pseudotumor cerebri. All of these things are worsened by obesity. But with every pound of weight loss, every single pound is the equivalent of 3 pounds of force off your knees, hips, and ankles, which means that the issues that people have with osteoarthritis, rheumatoid arthritis are substantially lessened. We also see reduced complication rates after total joint operation. So if you would need a knee replaced, which is a fairly common reason for doing this surgery, your post-operative recovery would be better. We also see decreased inflammation in the body, similar to what we saw with the asthma and the COPD, which is what improves the fibromyalgia and rheumatoid arthritis. We also see that with the decreased pressure in the abdomen from the weight loss, we also cause decreased cerebrospinal fluid pressures, which means that the headaches and neurological symptoms in pseudotumor cerebri are substantially lessened and oftentimes will resolve. We also have reflux as something that is substantially helped by the gastric bypass in particular. So the gastric bypass is the standard of care in reflux patients with a BMI of over 45, and that's actually changing to 40 in recent literature. The creation of the gastric pouch, so when we do this surgery, We separate one part of the stomach from the other, and that separates the acid producing cells from the esophagus. So you no longer have acid that can wash back up into your esophagus, creating that burning feeling. It also separates the muscle at the bottom of the stomach called the pylorus, which thereby reduces pressure within the stomach. So it's no longer pushing up. And then additionally, the weight loss decreases the pressure inside of the abdomen. Again, then we don't have anything pushing up towards the esophagus. And so that's another way that the gastric bypass will help fix reflux. Another issue is fatty liver, or NASH, which stands for non-alcoholic steatohepatitis. It's one of the leading causes of cirrhosis, hepatocellular carcinoma, and liver transplant. And it is the most common reason for those things to happen in patients who don't use IV drugs or alcohol. Bariatric surgery is the only treatment we have found to reverse the fibrosis and resolve NASH at 5 years. And it also will reverse the cardiac complications that are associated with NASH, including reversing the risk of heart attack, heart failure, stroke, and death. Another hot topic is PCOS and fertility. After bariatric surgery, the insulin resistance that you have with PCOS goes down, which reduces inflammation in the body. The estrogen is stored in your fat cells, which causes hormonal imbalance. But once you lose a whole bunch of weight, that estrogen kind of floods your system, and that corrects the imbalances that are caused by the PCOS. So this increases people's ability to conceive, and it also reduces the risk for problems once you do conceive, like preeclampsia, high blood pressure in pregnancy, gestational diabetes, and fetal macrosomia, which means babies that are too big, which can lead to other complications. There are a whole bunch of cancers that are positively affected by bariatric surgery. And those are a lot of different gastrointestinal cancers, essentially going all the way from the mouth to the anus. So we have esophagus and gastric cancer and bowel cancer and gallbladder cancer, and pancreas cancer, colon cancer, rectal cancer. All of those things are improved. We also see substantial improvements in breast cancer, ovarian cancer, and cervical cancer. The interesting thing about, and endometrial, the interesting thing about those is that even if you've already had, say, breast cancer before we do your bariatric surgery, your risk of recurrence of your breast cancer goes down. Same thing if you've never had breast cancer and we do bariatric surgery, your risk of having a first-time breast cancer goes down. And that's the same with blood cancers, multiple myeloma, lymphoma, and leukemia, and kidney cancers as well. And the last thing is that it improves life expectancy. Compared with really intense lifestyle changes, bariatric surgery causes a median life expectancy increase of 6.7 years, which means that if you don't have diabetes, but you have bariatric surgery, you add an average of 6.7 years to your life. If you do have diabetes, you add an average of 9.3 years to your life. And the great thing about this is that it's not just extra years, they're healthy extra years. So they're extra years with a better quality of life than you may have had otherwise. So as I said earlier, if you lose 10% of body weight, it does have substantial impacts on your health, but it's really difficult to lose that amount of weight and keep it off with diet and exercise alone. There are so many biological factors that make maintaining weight loss really difficult. We're battling against thousands and thousands of years of evolution, essentially. So only 16% of patients who are obese manage to maintain that 10% weight loss that I said was so critical for 1 year at any point in their lives. And think about the number of times most of us have tried to diet. Only 10% ever manage that for a year. And it takes very intense lifestyle intervention to achieve that weight loss. Those who do lose that 10%, after 1 year, 35% will have already gained it all back, and over 50% will have gained it all back by 5 years. However, with the bypass, we see that only 10% of patients regain their weight, right? So we're looking at that in comparison, the chances of losing the weight and keeping the weight off with the Roux-en-Y gastric bypass is substantially higher. So the average weight loss with this is 65 to 85%, way higher than that 10% we said that we needed to lose to start seeing those benefits. And from a cost perspective, the lifetime savings is between $141,000 and $428,000, which means that you and your insurance company are already saving money by 3 years after surgery. So what makes a bariatric patient? There are definitely some requirements we have in order to qualify for surgery. So you need to be qualified or classified as severely obese, which means that a BMI of 35 plus at least one, and sometimes two, depending on the insurance plan, other medical conditions. And the big five are high blood pressure, high cholesterol, diabetes, sleep apnea, arthritis, and actually I would add fatty liver into that as well, the big six. If you have one of those, typically it's pretty easy to get things approved. Now, in patients with a BMI of over 40, you don't necessarily have to have those comorbidities in order to qualify for surgery. And in some plans, there's a BMI cutoff of 32 for people of East Asian descent. Now, the ASMBS, which is the governing body for bariatric surgery, has come up with new guidelines recommending that we have a BMI of 30 plus comorbidities and a BMI of 35 with or without comorbidities. But typically, the insurance companies are a good 5 to 10 years behind the healthcare recommendations. So we'll have to wait and see when those go into effect. So there is a bit of a journey in order to get through to surgery. First, you meet with your surgeon and you discuss which path is right for you. At that appointment, we typically will go over the different types of surgery, look at your particular medical conditions, and figure out your preferences in addition to the medical recommendations and decide which surgery is the way to go. Then we'll have you do nutrition classes. You do a psychological evaluation, and that's essentially to make sure that there aren't any underlying psychiatric issues that could make surgery unsafe that are not treated. Okay. If they are treated, we're not worried about it. And then your insurance company may require you to do some physician supervised weight loss. And that is entirely decided by your insurance company. We don't have any way to get around that. Typically, patients will either do an upper GI or an EGD or other indicated tests or clearances. And then you do your preoperative class, which is kind of an overview of everything, going over everything that you've already learned. And then your trip to the operating room. Post-operatively, patients stay in the hospital an average of 1 to 3 days. Probably about 80% of patients go home post-operative day 1. And the average time off of work, studies show, is about 10.2 days. Now that, of course, does depend on what you do for work. Some people can go back earlier. Some people need to stay later or stay off longer. We have you do lots and lots of walking and drink thin liquids with protein shakes for 2 to 3 weeks. Then we have you do pureed foods for 2 to 3 weeks, then soft foods for 2 to 3 weeks. Rule of thumb there is you need to be able to cut it with the side of a fork. And then you're off to the races, normal food after that. We do want you to be on bariatric specific multivitamins for life, just because your body can absorb those much better than regular multivitamins. And we do expect weight loss to start right away. And we'll see about a half a pound to a pound a day for the first month. That's my good stopping point of my overview of bariatric surgery. Any questions so far?
Yes, we do have some questions coming in. So first of all, I think you mentioned on a previous slide about the like the BMIs and things would be applicable for surgery.
Mm-hmm.
Is there a specific type of arthritis that would be considered a factor in getting approved for surgery?
Essentially, you just have to be in some sort of treatment for the arthritis. So if you are getting injections, or they have plans for surgery, or essentially you have to, or you're getting pain medications for it, something like that. There has to be some sort of treatment. Now, if it's rheumatoid arthritis, you would need to be on some sort of biologic drug, or something like that. We have to show that your arthritis is bad enough that you've needed some sort of medical intervention, and then it counts. So it's not necessarily the type of arthritis so much as the severity.
Gotcha. Makes sense. Can you discuss a little bit what some of the long-term risks are after bariatric surgery?
Sure. So after bariatric surgery, one of the things that we worry about is the possibility for vitamin deficiencies, which is why I mentioned those bariatric multivitamins. It is something that most bariatric surgeons will check about once a year to make sure that we don't need to tweak any of those vitamins. And then along with that, we see, depending on the surgery, a higher risk for iron deficiency anemia, particularly that would be more with the bypass and the switch than the sleeve, and the possibility for osteoporosis. So taking all those vitamins are really important. Beyond that, in terms of possible adverse events, it's really dependent on which surgery you would choose. So with the sleeve, we see issues with reflux after the fact. With the bypass, there is the possibility for marginal ulcers, which would be ulcers near the anastomosis. We'll kind of go over that a little bit later on, but and there are some things you can do to decrease your risk of that, like avoiding alcohol, avoiding smoking, things like that. There's also a possibility for something called an internal hernia, which means that things get twisted. There are some extra steps that most surgeons will take to decrease the risk of that happening. And it's our policy at St. Agnes that we all take those extra steps to decrease the chances of the twist happening, but that it is a possibility.
Okay, great. And can you talk a little bit about what maintenance is like after surgery, and what are, the probabilities that you will regain the weight?
So that does depend a little bit on, again, it does depend a lot again on which surgery you choose. So with all of the surgeries, we will see you at 2 weeks, 6 weeks, 3 months, 6 months, and 12 months post-op, and then once a year forever, so that we can keep talking about, keep going over things, checking on your vitamins. If you're having any issues, address them at those appointments. Once you are in the maintenance phase, we are still going to want you to track at least a couple of days a month, make sure you're getting in enough protein to support your body systems. And then the possibility for weight regain is highest with the sleeve. It's between 30 and 40%, depending on which study you look at. Okay. With the bypass, it's about 10% at 15 years. And with the duodenal switch, it's about 2%. So it does depend on a lot on what surgery you choose.
Okay, great. Could you talk a little bit about what types of insurance will cover the surgery, or what kinds of insurance that we accept, and if there's any like ballpark out-of-pocket costs that a patient could expect?
Well, so in the state of Maryland, as long as you have a Maryland insurance, they are legally required to cover bariatric surgery. So it's not something that we have a lot of problems with around here. Now, if your insurance is through your work in Virginia or something like that, that could be a different story, or Pennsylvania. But in the state of Maryland, it's required to be covered. So we don't see a whole lot of problems with that. And so then your out-of-pocket cost is essentially be your deductible. If you were to decide to pay out of pocket, you're probably looking at around $20,000 out of pocket for the whole thing. And that's, of course, a ballpark.
Great, thank you for that. We've got a couple questions here about kind of the benefits of bariatric surgery versus a weight loss medication like a GLP-1 compound or things like that. Can you kind of discuss a little bit of the difference and when you might consider one versus the other?
Absolutely. So the GLP-1 medications are really good for patients, particularly with a BMI of less than 35, who would not qualify for bariatric surgery. And really, they work pretty well up to a BMI of maybe 45, definitely 40 and under. if you're interested in it, it could be worth trying. With BMIs higher than that, the medications are just not strong enough to give lasting results and to lose enough weight to make a big impact. The weight loss drugs are not as strong as bariatric surgery. So again, the amount of weight loss that you're hoping to get will affect the decision. The other thing is that with these weight loss drugs, you do have to be on them for life. We are now having studies coming out that are showing that once you stop the weight loss medications, you regain all of the weight plus some, typically within 2 years. And so, that's something to keep in mind. If you're paying for it out of pocket every month, that's going to get really expensive over your lifetime. And then, these medications are great for patients who maybe aren't a candidate for bariatric surgery, or as a bridge to get to bariatric surgery, in patients who need to do that preoperative dieting and they have a BMI of 55 or something, just throwing out a number, being on these medications can help knock off maybe 30 pounds over that 6 months and make the surgery a little bit easier and safer once it comes time for surgery. So it's another use for those.
Okay, great. And are these weight loss medications something that you offer at your office, or would you talk to your primary care about that?
So typically you would talk with your primary care doctor, though if you don't have one or your primary care doctor doesn't offer those medications, there are a couple of obesity medicine specialists that we can connect you with that would be able to help you with that as well.
Okay, great. Let's take one more question now, and then we'll jump into the second part of the presentation and then circle back for some more questions. Would a history of prediabetes and elevated cholesterol count as a comorbidity?
So prediabetes typically does not, but elevated cholesterol does. And so it would depend a little bit on how elevated and whether or not you're ever on medications. But oftentimes in patients who do have elevated cholesterol, they also have at least the start of NASH or fatty liver, which can be determined just by ultrasound, which is a pretty simple test. And it's not a particularly invasive, not at all painful test. And so if you do have elevated cholesterol, but you're not on any medications, we're worried that we may not be able to get approval without the comorbidities. Then an ultrasound most of the time will show NASH, and then we're good to go.
Perfect. Thank you for that. All right, let's go ahead and dive into the second half of the presentation, talk a little bit about the different types of procedures, and then we'll come back for some more questions.
Wonderful. All right. So there are several different surgical options. Bariatric surgery itself encompasses a group of operations that help with weight loss by making changes to the digestive tract. These are typically done minimally invasively, which means little bitty poke hole incisions. And then those would be the primary operations, and then revisional operations, which would mean that you've had bariatric surgery before, and then we're going in to do a second surgery. So the one that we'll talk about first is the vertical gastric sleeve or sleeve gastrectomy. That is the most commonly performed procedure in the United States today. I typically reserve this more for patients with a lower starting BMI, just because the weight loss is less. It's about 50 to 65% excess body weight. So if you have that higher starting weight, it's going to be more difficult to get down to the healthy range that we're hoping to get you to. That's not to say that that can't be done. It absolutely can, but it does require a little bit of extra dedication to lose that extra bit of weight. I also reserve this for patients who don't have any history of reflux, as this particular surgery can make reflux quite a bit worse, and we'll talk about that in a little bit. Because this is a purely restrictive operation, we don't see the rates of comorbidity resolution like in conditions like diabetes and PCOS as much as we do with some of the others. And then also because it's only restrictive, it only works with one method, the rates of weight regain are higher. So the way that we do our sleeve gastrectomy is we do 4 little poke hole incisions, and then we take a stapler. It's taken parallel to the smaller curve of your stomach. So we take that stapler all the way up and remove about 80% of your stomach. So it goes from holding about 6 cups of food to holding between a half and a whole cup. Now, when we do that, it increases the pressure inside of your stomach, kind of like you're putting your thumb over the top of a garden hose. You know how you do that and then water goes everywhere. Well, when we take this piece of the stomach out and hold our thumb over the top of this garden hose, in about 20% of people, that can cause stuff to go up your esophagus rather than down into your intestines like we want it to. So that's the cause of the reflux. And because of the reflux and the fact that the weight regain is higher, we do see higher reoperation rates of sleeves, which is between 30 and 40% now. The next case we'll talk about is the Roux-en-Y gastric bypass. So this is kind of our gold standard. It's been around since the 1950s. We typically do offer this to any patient with a BMI of greater than 35, but it's particularly good in people with diabetes, because we see resolution rates of diabetes of about 86% initially. And we think that this is because the pancreas, where it dumps into the small intestine, no longer sees food. So the pancreas gets a bit of a rest, and that helps it to recuperate and make that diabetes go away. And typically the diabetes is gone by the time you leave the hospital after surgery. So day after surgery, diabetes is done. We do see an expected weight loss of about 65 to 85% with this particular procedure. We do see a full weight regain in less than 6% of patients, and that is at 20-year follow-up. So the rates of weight regain, that's a really hard thing to say, is substantially lower with the bypass. It also treats GERD in patients with obesity. And as I said before, that works in a couple of ways. One is that the acid secreting cells are separated from the part of the stomach that's attached to the esophagus. 2, it decreases the pressure because we are separating out the muscle at the base of the stomach that keeps the pressure high. And 3, because the weight loss reduces the pressure pushing upward on the esophagus. So this is a picture of the gastric bypass. We have up top a small pouch that is separated from the rest of your stomach. And you can see with where that top green arrow, that's about where your pancreas sits. So that's the bypassed duodenum, which means that it's only seeing acid and enzymes from now on. The food follows the path of the red arrows, okay? So the pouch holds about 30 to 50 cc's, so it's quite small. And then we attach some of your small intestine up to the pouch. That's called your roux limb. And that is typically somewhere between 100 to 150, maybe 200 centimeters, depending on your surgeon's preferences. And then the one with the green arrows, that's just the digestive enzymes, is the biliopancreatic limb. And that is typically somewhere between 75 to 125 centimeters. Again, surgeon's preference. And I actually will change the length of that depending on whether or not you have diabetes. And that's attached to the remnant stomach and then is anastomosed down to the roux limb. And the last procedure we'll talk about, last primary, is the duodenal switch. So there are actually 2 types of duodenal switch, and we'll talk about both today. The duodenal switch itself is historically reserved for those with extreme obesity or uncontrolled diabetes. So your hemoglobin A1C is 10 plus, or a BMI of over 50. Now, sometimes insurance companies will cover this with a lower BMI, but we've seen that as the most common cutoff. The excess body weight loss with the duodenal switch is the highest of all the procedures. It's 85 to 95% excess body weight. Thus, patients are able to lose hundreds of pounds if they're starting off hundreds of pounds overweight. And it does have the lowest rates of weight regain. It's less than 2%. We do see a resolution of diabetes greater than 90%. And this is probably because the length of the bypassed intestine past the pancreas is the longest with this procedure. Though we do see with the traditional switch, more frequent bowel movements, averages about 4 to 6 per day, and they will probably be stinkier and smellier than you are used to. So with the traditional duodenal switch, it's like the sleeve and the bypass had a super baby, right? So we see a sleeve up at the very top, and then we bring the piece of your small intestine that's attached down to your large intestine up, and we attach that to the base of your stomach. Then we see that same biliopancreatic limb that we saw in the bypass. That's then brought around and reattached down closer to the base of your small intestine near where it goes into your large intestine. So with that, the enzymes in the food only combine for about 100 to 125 centimeters. So we do see the highest risk for malnutrition related complications with this particular surgery. You only are able to absorb about 20% of fat. So any fat soluble vitamins are at high risk for getting too low. And we are bypassing about 75% of the small intestine. So I do have a video of the traditional switch. So here, there's the stomach. We create the sleeve up at the top where that larger piece of the greater curvature of the stomach is removed. Then you divide right after the stomach and the small intestine separate from each other. You divide the small intestine kind of near the middle. And then you bring up one end is brought up to attach to where we've divided the stomach and the small intestine. The other end is brought down there to the base. So you can see the food is the blue, the enzymes are the yellow, and you can see that they stay separated for quite a long time. And all that space that the blue is going through, the food is not being really digested and absorbed. And then they mix together down at the bottom. That's where the absorption happens. Okay. No, we've already done this. Okay. So this next one we'll talk about is the single anastomosis duodenal switch, or the SADY. And that stands for single anastomosis duodenal bypass with sleeve gastrectomy. But SADY is much easier to say. So with this one, again, we do a sleeve up at the top, just like with the other one. However, the difference comes in that we go from where the small intestine and large intestine meet, and we count back about 300 centimeters, give or take, and we attach that loop up to the duodenum. So the benefit to this is that you're still skipping a large part of the intestine, but rather than 100 centimeters to absorb, you have 300 centimeters to absorb. So you're still bypassing a lot, but the risk of vitamin deficiencies and malabsorption is substantially less with this surgery. Now, compared to the traditional duodenal switch, you do lose a little bit less weight. You'll lose about 10 pounds more with the traditional than you will with the SADY. But comorbidity resolution is exactly the same. And we see the risk profile is about 7-fold less with the SADY. So I definitely prefer this operation to the other one if you were to come and see me for it. And also, nice benefit is that with the other one, you see 4 to 6 bowel movements per day. And with this one, you average about 1 to 3, though they are still smelly. So here's a video of the SADY.
Bowel. The single anastomosis duodenal switch, or loop DS, begins with a sleeve gastrectomy in which a thin vertical sleeve is created using a stapling device. This sleeve will typically hold between 100 and 150 milliliters and is about the size of a banana. The resected portion of the stomach is removed. The small bowel is divided approximately 3 centimeters beyond the stomach, preserving the pyloric. The end of the small bowel is located, and about 3 meters of small bowel are measured. At this point, a loop of the small bowel is brought up to the duodenum and joined as shown. By altering the anatomy of the gastrointestinal tract by creating the gastric sleeve and altering the path and anatomy of the small bowel, the single anastomosis duodenal switch changes signals in the body, resulting in decreased hunger.
All right, so you can see with this one that the blue is, well, the purple, I guess, is the food with this one. The yellow is the enzymes, and you can see where the green and the blue match up, that's where your absorption happens. I'm not really sure why they made it both blue and green, but that is the length of the absorption. So it is a fair bit longer than the traditional switch.
Bowel. The sick.
So last we'll talk about revisional surgery. Revisions mean that you have had a bariatric surgery in the past and are now undergoing a second procedure. We do this in patients who have uncontrolled acid reflux or Barrett's esophagus, which means that they got precancerous changes in the base of their esophagus due to reflux. We do it for weight regain. We have new onset of comorbidities, meaning that your high blood pressure or diabetes had gone away, or you had never had it before and now suddenly you do. Refractory ulcers, twists, or strictures. Insufficient weight loss, which means that you had the procedure and you either are not satisfied with the weight loss, or your insurance company is not satisfied with the weight loss, or it wasn't enough to get rid of the comorbidities that you had. Bile reflux and malnutrition. So typically, if you were to be looking to have a revisional surgery for weight regain or new onset of comorbidities, we could revise the existing operation, which we can absolutely do with the SADI or duodenal switch or gastric bypass. However, with the sleeve, re-sleeving somebody, so making the sleeve more narrow, doesn't work. It ends up with about 5 pounds of extra weight loss, which is not worth undergoing another surgery. We can also convert to another operation. So a sleeve can easily be changed to a bypass or a SADI or a traditional switch. And the more that the anatomy is changed, the bigger the impact. If you were to come with reflux or Barrett's esophagus, we would convert the sleeve, which is typically the operation with which you would have reflux, over to a gastric bypass, which would then fix the reflux. And then if you were to have malnutrition, meaning you lost too much weight, we can place temporary feeding tubes. Typically, those would stay in for a month or two, and once weight went back up, we'd be able to take that out, or we could decrease the amount of bowel that's skipped. So this is a cartoon of the sleeve to the bypass, which is the most common revision that we do. With this one, we essentially divide the sleeve in half, bring up a piece of the small intestine and attach it to the top half of the sleeve. The bottom of the half of the sleeve and its small bowel are then brought around and reattached to that small intestine down below. Thank you. Any questions I can answer?
Thanks, Dr. Swift. That was a lot of great information, and we have a lot of questions.
Okay.
First up, can you kind of describe how bariatric surgery is different from like a liposuction procedure?
Yes. So with a liposuction procedure, you would be sucking out the fat cells that are underneath your skin. So it's a purely cosmetic thing. With the bariatric surgery, you're actually losing that weight. And so we see all of the positive impacts on your health with the bariatric surgery. And then in the future, if you would want, so that will fix those comorbidities, and then also it would decrease your chances of regaining weight back, right? With the liposuction, unless you were to substantially change your diet, that weight will come back. And then, after bariatric surgery is done, if you have lost sufficient weight and you want some extra skin removed and things like that, that would be a better time and a more effective, long-lasting way to get the body shape that you were looking for.
That's great. Thank you. Can you talk a little bit about the recovery time after surgery? Is this an outpatient procedure? How much time would you expect to take off work for this kind of surgery? Kind of like those things like that.
So probably about 80% of our patients leave the day after surgery. Typically it's around lunchtime. And so it is one overnight stay in the hospital typically. Now, obviously, if you're not feeling well, you're having nausea, things like that, it's not a problem to stay extra time if you need to. The average time off of work is about 10.2 days. Now, for my patients, I tell them if you work from home, you're working at a desk job, something like that, I'm totally fine with you going back earlier than that 10 days, that 2 weeks. If you have a job where you're doing lots of heavy lifting, manual labor, it may have to be longer, 4 to 6 weeks, depending on the job. So it's quite dependent on what it is that you do, but average is about 10 days.
Okay, perfect. And is that kind of the same for all of the procedures that you went through? Okay, great.
Exactly the same for all of them.
Perfect. In terms of revisions, so if a person had a procedure in 2017,
Mhm.
are they able to have a revision surgery for for a gastric bypass?
Probably, yes. So every now and then we come across an insurance plan that has a stipulation in it that you can only have one bariatric surgery in your lifetime. So if that's the case and the surgery is purely for additional weight loss, then it's going to be difficult to get that covered. However, if you have any issues with reflux or anything like that, then it becomes much easier to get covered. But yeah, having had surgery in 2017, um, you absolutely would be a candidate for a revision surgery or conversion over to bypass or something like that at this time. Yeah.
Okay, great. So when you're talking with prospective patients about which type of surgery would be most suitable for them, do you look at what oh my gosh, excuse me, comorbidities the person has and kind of use that in your recommendations? For example, if a person has diabetes, would there be one procedure that you might recommend over another?
Yes. So typically, if you have diabetes, I lean towards the bypass or the SADI more than I would the sleeve, just because we see the resolution rates of diabetes um, so much higher with the bypass or the switch. And that your diabetes is gone by the time that you leave the hospital. So it's very quick to make that go away. So if you were to have diabetes, I would lean towards those procedures. And then from there, we would look at BMI and which one would be most appropriate. But of course, it is your body and your choice. So I would make the recommendation that yes, a bypass and the switch is going to be better for you medically speaking, but then of course the choice is yours.
Perfect. So things like diabetes, would pre-diabetes fall under that category as well? We've got a couple other questions about like high blood pressure and PCOS in terms of like,
Yeah,
would that make them good candidates and particular
right.
procedures that you might recommend?
So with PCOS, it goes hand in hand with diabetes, and it all relates back to the hormonal imbalances and the insulin resistance. So again, with prediabetes, I would be more in favor of doing a bypass or a switch with those patients. With high blood pressure, we actually see over 90% resolution with all three procedures. And so I'd be less likely to lean one way or the other. With sleep apnea, we actually see higher resolution rates with the sleeve and the SADI than we do with the bypass. So if you had bad sleep apnea, we would talk about those two procedures, unless you had reflux. And then if you have reflux, we would go back to the bypass. So I definitely take all your other comorbidities, all your other medical conditions into account when we discuss, which I think would serve you best.
Perfect. We have a question about which of the procedures has the highest risk and which one has the lowest risk. Is that a kind of a clear-cut answer, or does that kind of depend on, the individual?
Yeah, so um kind of both. So I guess technically the lowest rates of complication would be the sleeve because the biggest, unless you're counting reflux, right? If you're counting reflux, then the sleeve has the highest risk of complication. But if you're not counting reflux as a complication, then the sleeve, where you're just stapling, would have the lowest risk. With the bypass and the SADI, you're both stapling and reconnecting. So you have two different areas where there's a possibility for a complication to happen. Now, the rates of complication aren't high. They're with the sleeve, it's about 1 in 800. With the bypass, it's about 1 in 600, and with the SADI, it's about 1 in 400. So, but the sleeve is technically the lowest risk because you're only stapling rather than stapling and reconnecting.
Makes sense. Okay. Is a patient able to choose what percentage of the stomach they wish to have taken out? So say they want to do like 50% versus like the 80% that might be recommended.
No, not really. We have to go by the size of the tube, and the tube is limited by how big your esophagus is. And if we do a much bigger tube than that, it can tear your esophagus, which is quickly deadly. So we don't really mess with that too much. We've also found that if you leave much more than that 80%, say you take away 60% or you take away 40%, the average weight loss drops substantially to the point that you then don't really end up losing weight after that surgery. So the 80%, between 70 and 80% is pretty standard.
Gotcha. Okay. So after a person has bariatric surgery, are they still able to have children in the future? Is that a safe option?
Oh, yes, absolutely. So we do recommend that you wait at least 12 and preferably 18 months after surgery before trying to have children. And the reason for that is that right after surgery, you're obviously getting fewer calories than your body is used to. And once you get pregnant, your body diverts a lot of its resources to the fetus, right? So that means that your body is it was already getting less than it likes, and now it's getting even less because things are being diverted to the fetus. So that can make a dangerous situation for you. So absolutely it is safe, but we want you to be out of the rapid weight loss phase before you would get pregnant. Now, we do see, if you're having issues with infertility, we do see fertility rates improve. So your chances of getting pregnant are higher. And we actually see plenty of, oops, I've been infertile for the last many years, and now it's 2 months post-op, and I figured I still was, and I'm not anymore. So we do see that happen a couple of times a year. And then also, once you're out of that rapid weight loss phase, preferably you've waited, then your risks during pregnancy and during childbirth actually decrease. So your risk of C-section is lower, your risk of gestational diabetes is lower, your risk of preeclampsia is lower, and all these other things. So it's actually safer to get pregnant after bariatric surgery than before.
That's great. Thank you. Also after surgery, will additional surgery be necessary to remove excess skin after weight loss? And if so, is that something that your office provides?
So that very much depends. That's on a case-by-case basis. There are a couple of things that will kind of determine whether or not you're going to have enough excess skin to need it removed. One, I mean, obviously personal preference, right? I have plenty of patients who just don't want to bother with skin removal, which is totally fine. The amount of weight you lose will determine how much extra skin you have, as will your genetics, and whether or not you've ever smoked. So those three things really play into how much extra, and your age at the time of surgery. So those things will really play into how much extra skin that you will have. We do work with some plastic surgeons who do take insurance through St. Agnes. And typically, so there are no insurance companies that will allow you to have the skin removed until you're at least 18 months out from surgery. So typically at the 1 year post-op visit, we'll talk about whether or not you want to see a plastic surgeon, and then give you a list of plastic surgeons that we recommend. So it is not something that the bariatric surgeons would provide, but we do have people that we work with that would be happy to help you out with it.
Great. And are there any non-surgical options that you recommend for helping to tighten loose skin after or during weight loss?
We have lots of people using compression garments, and then I am a big fan of lifting heavy weights. Building muscle underneath the loose skin really helps with the appearance and will help to tighten things up more so than anything else.
Perfect. And does smoking have any impact on loose skin?
Yes. So smoking will interfere with the elasticity, so the stretchiness of your skin. And if your skin is more elastic, meaning its natural stretch is preserved, it will shrink back better than if the elasticity is decreased. So smoking decreases your elasticity. So smoking will increase your chances for having excess skin.
Makes sense. Okay. We have a few questions related to patients who have extremely high BMIs, like over 500 pounds or so.
Uh-huh.
Is there anything that they can do or that you would recommend doing prior to surgery to reduce your risks of the surgery itself?
Sure. So, like we talked about earlier, that would be one of those cases where those GLP inhibitors can be helpful to decrease, get an extra 30 to 50 pounds off. The real concern with surgery at that point is getting you off of the breathing machine because your chest has a fair amount of weight to it. Um, so that's always an option and one that we would never try and talk you out of, right? Anything that would decrease your risks of needing to stay on the breathing machine extra time. The other thing that we do is have people do what's called a liver shrink diet. And so I have people go anywhere from 2 days to 2 weeks doing a mostly liquid, high protein diet, and that shrinks your liver by at least 20%. And that makes the surgery a lot safer because your stomach is actually tucked underneath your liver. So it makes our ability to lift up your liver and access the area that we need much safer.
Great. Another question regarding weight loss drugs. Is it true that weight loss drugs can slow down your colon, so they're not recommended for people with diverticulitis? My goodness,
Diverticulitis.
another word. Thank you.
Yes, that is absolutely true. That's one of the main ways that these GLP medications work is to slow down the gut. So they decrease the emptying of your stomach so your stomach feels fuller for longer, but it doesn't only work on the stomach, it works on the whole GI tract. So everything moves through much slower. So yes, if you have a history of diverticulitis, it can put you at risk of having another diverticulitis episode.
Okay, great. Is there a particular age or gender preference for any of the surgeries? So if a person is over 40 years old, is there one that might be recommended for over another?
No, not particularly. I would say I would be less likely to do a duodenal switch in a patient who's less than maybe age 25, though that is not 100% true. It will very much depend on their starting BMI. If their BMI is 80 and they're 18, we would still discuss the SATI just because of how dire their risks are at that point. So really, again, it's a case by case basis, and I don't have a particular age cutoff for any of my surgeries.
Okay, great. What are the mortality rates or risks that are associated with these procedures, and how invasive or high risk would you consider them?
So the mortality rate is about 1 in 2,000. So it is quite low. And actually, the risk of having your gallbladder removed is higher than the risk of these surgeries. So they're very safe surgeries. In terms of the risk of complications, as we discussed earlier, it's a little bit lower with the sleeve and a little bit higher with the SATI. So, but all of them are very safe surgeries. And as I said, with as common as gallbladder removal is, these surgeries have lower complication rates than that one does.
Okay, great. I think we have a couple of questions about revision. So are any of the surgeries that you talked about today, are all of those considered reversible?
So the only one that is technically reversible would be the gastric bypass. And that is, so once this, with the sleeve and the SATI, once we take the stomach out, we put it in a jar, send it to pathology, never to be seen or heard from again. We definitely can't put it back once it's in our jar, right? But with the gastric bypass, you can technically put the two pieces of the stomach back together because everything remains inside of your body. So it's not something that we do very often, but it is definitely something that we are able to do if we need to.
Makes sense. Okay. I think we touched on these a little bit earlier, but if we could just kind of repeat, Will insurance cover a revisional surgery, and what might be like your ballpark out of pocket expenses related to the surgery?
Okay. So with a revisional surgery, if it's purely for weight loss, then the answer is maybe. Every now and then we see an insurance company that has a special rider on their policy that says that if they will only cover one bariatric surgery per lifetime. So if it's purely for additional weight loss and you have a policy that states that, then we wouldn't be able to get it covered. Now, if we are doing the revisional surgery for a quote unquote complication like reflux, then yes, that would typically be covered, and it usually isn't too big of a fight in order to get that covered. Now, even if the weight loss is, or if the revisional surgery is purely due to additional desired weight loss, most of the time those will be covered as well. We just have to document that yes, you are compliant with the diet and all that stuff the first time around. And this is just the nature of this particular disease. It's a chronic disease, right? And so we're just managing it. So most of the time, yes, it is covered unless you have a policy with that exception. If your policy does have that exception where you only have one lifetime procedure, then it'll typically be somewhere around $20,000 out of pocket.
Great. Excuse me. Where did tummy tucks fall into this category? Is that considered related to bariatric surgery, or is that more on the cosmetic side?
It would kind of depend on when you did it. So if you were doing it instead of bariatric surgery, then it would be cosmetic. And as I said before, the risk is that you would regain that weight because you haven't changed any of your gut anatomy. So if you're currently gaining weight, you cut that stuff off, you will regain it again in the future. However, if you have had bariatric surgery, typically after about a year, we'll start talking about a tummy tuck or skin removal surgery and refer you to a plastic surgeon. And then the actual surgery would usually take place about 18 months after your bariatric surgery. So at that point, it's no longer purely a cosmetic procedure. It would be removal due to excess skin from the surgery.
Makes sense. Okay. After the surgery, what level of pain or discomfort could a patient experience? Is there like a lot of abdominal pain that goes into it, or kind of like how's that recovery process?
Typically not a lot of abdominal pain, though of course pain is different for everybody and everybody experiences things differently. So, but with my patients, typically the average is to take about 6 doses total of pain medications after surgery. I would say the vast majority of my patients don't take any of the narcotic pain medicine that we send them home with. When I see them in post-op, they tell me, nah, I didn't even take it. I didn't need it by the time I got home. I could do Tylenol and I was good.
It's a good benchmark. Yeah. Is it true that weight loss medications paralyze the stomach so that you don't feel hunger or fullness? And is this the same with bariatric surgery?
So it's technically not paralyzed. It is able to move, but it's really sluggish and slow compared to what it is now. Now, we don't have the same thing with bariatric surgery where your gut slows down. However, since we are separating out the things, we're separating out a lot of the I've lost the word that I was looking for. A lot of the hormones and things that cause you to feel hunger, those are now separated, or sometimes that part of the stomach is removed. And so most people don't feel hunger or feel substantially reduced hunger after surgery. Most of the time, those hunger signals will come back, usually within a year. Not always, but usually within a year, you do see those signals coming back. But a lot of people don't have hunger after surgery.
Great, thank you. Okay, so did you just flip the slide?
I didn't touch anything. It just.
Oh, interesting. Well, we're almost at the end anyway. We've got like 2 more questions on here.
Sorry about that.
No worries. So yeah, 2 more questions on here.
Okay.
First, are all of the surgeries safe for persons who have had their gallbladder removed?
Yes.
Okay, perfect. And we just have 1 more. And does the surgery have any negative interaction with depression or anxiety medications?
It's rare. We do see in people who have had severe issues with psychiatric illnesses, who have needed inpatient psychiatric care before, or issues such as schizophrenia. We do see that about 1% of those patients then need inpatient psych afterward. But it's pretty rare. Now, when we do ask that you let your psychiatrist know that you're having this surgery, because occasionally we do see people needing dose adjustments. I would say that probably happens in about 5% of patients, that they need a dose adjustment after surgery, but the vast majority of patients see no difference whatsoever in their anxiety and depression.
Perfect. Okay. And our final question this evening, oh, just kidding, one more. So if you mentioned earlier about like kind of the progression of checkups throughout over time. So if everything is going well, why would you still need to continue to have those lifetime checkups, or is there ever a point where you would stop with that?
We always prefer to see you forever. And the reason for that is that the labs and things that we check are weird. Your primary care doctor is not going to check those things. The only people who care about them are bariatric surgeons, because of the way that we've messed with your gut. And so we would encourage you to keep following up with us so that we can check those things. With some of these vitamin deficiencies, they can occur years down the line and they can cause permanent damage. So we don't want you to go too long without checking them, when it's something that could easily be prevented.
Okay. And at what point do you switch to those yearly checkups?
After a year, typically, though I do have some people. So, I said we see you at 2 weeks, 6 weeks, 3 months, 6 months, 12 months, and then once a year.
Yeah.
So I would say maybe about half of my patients at the year point want to see me again at 18 months, and then we go to 2 years, and then 3 years, and then 4 years. So it's a little bit patient preference, but after a year, it's been shown to be safe to go to yearly appointments.
Okay, perfect. So for a person that's interested in learning more, what would be the first step to finding out if bariatric surgery is the right answer? Should they start with their primary care provider? Do they need a referral to go to your office? How does that process work?
I believe that most people do need a referral. And so then, yes, that would come through your primary care doctor. Now, I think there every now and then is an insurance company that doesn't require that, but that would be policy specific.
Perfect. And that wraps up all of our questions. That was a lot of great questions from the audience. We really appreciate that. So before we wrap up for today, if you think of any additional questions or you'd like to get more information, you can reach out to Dr. Swift's office. That's Ascension St. Agnes Bariatric Surgery. And the number for that office is 667-234-8725. Or you can find more information on mdbariatrics.com.